Good evening, everybody, and thank you for tuning into this Author Hub webinar. It's been a hell of a journey for us producing all this web content. It started out pretty small, and so I've got to plug Author Hub just a little bit. It started out with just a few podcasts, and those are well received. And then we moved on to doing webinars, and we've been trying in everything we do to do something slightly different, and bring a bit of an edge to it that's not, you know, just the standard thing. If you take our last webinar, for example, it was on ankle fractures and Lisfranc, and we got some awesome guys doing it. And I tell you, so we put up some cases beforehand, same as we did for this. We put some cases up beforehand. And if you've not seen Lyndon's anatomic dissections and his approaches to the ankle, particularly the back of the ankle, you've got to see it. It's all there underneath the cases, his response to how he fixes each one and how he does the dissections is brilliant. And that's kind of where we're headed with these. We're trying to produce not just like bog standard webinars and stuff, but we're trying to produce something that's a bit more three-dimensional, 360, blended learning, call it what you will. 2 weeks time, 22nd of July, resilience. That's what we're on about. And I plugged this last time. I'm not going to go on about it, but this is increasingly topical. And, you know, we all spend a lot of our time wondering, wishing we were perhaps a little bit more resilient. This is today, and we've got an awesome faculty. And first of all, I'd like to introduce my buddy, my workmate, Nima Heidari. He's been on this platform before, and today we're talking about limb recon. Nima, it's going to be a limb recon bonanza. So what is it about? What are the guys expecting today?
Well, thank you very much, Pete, and thank you very much for the invitation second time round. Limb recon is a discipline that's concerned with providing a limb which is pain-free, with a united bone, which is infection-free, with a robust soft tissue envelope to try and restore function. And it's a very variable feast. It requires a sort of a skill set that some people may not have or may not even want to sort of go into. But today we've got a group that are interested in this so that you and our colleagues understand what is feasible, when to refer, what to refer, and what the patient journey is likely to be. So it brings me great pleasure to introduce Hemant Sharma. He is up in Hull. He is a very highly respected limb reconstruction surgeon. And today he's going to talk to us about deformities, how to correct deformities, and the good and the bad about it. So Hemant, it's over to you.
Thank you, Nima, and I'm looking forward to this. It's going to be a wonderful session with my other colleagues. So what I aim to do is, I'm hoping that by the end of this talk, I will be able to deliver some basic principles of the deformity analysis, and along with understand and utilize the osteotomy rules to a day-to-day practice and actually help us to find an appropriate method of fixation utilizing the analysis and the osteotomy rules. And hopefully some people who are less used to the deformity planning still should be able to plan a simple uniplanar deformity. Now, deformity as we see it, we always talk about apial and lateral views. But if you look at it, and we do x-rays in two views. Actually, deformity is a three-dimensional problem. We always tend to ignore the z-axis, although we talk about it a lot, length, and the shortening and all that is an axial translation along with rotation. But we don't seem to combine all three axes, because each time you see a deformity, I think we should need to look at it in a three-dimensional and correct it and plan it in a three-dimensional way. My name is Hemant Sharma. I work in Hull in a limb reconstruction and bone infection unit with a couple of my colleagues. And hopefully I'll be able to give you a taste of the deformity today. Now, I'm not trying to advertise the course, but actually what I'm trying to tell you is that we run a course for 4 days talking about these deformity, understanding, discussing, and planning and practicing. And I'm going to try to give the whole thing to you in about 15 minutes. So can be a little bit tricky. So if you have any questions, please ask me separately at the end of the webinar. And if anything else you need, please feel free to contact me. Now, the principles were around a long time, but I think George Bailey combined the principles and formalized them and put it in quite a large book, which is freely which is available. Michael Laverick, a lot of you will know, is the first one who started deformity planning in UK, and certainly he's my teacher, and certainly a lot of us has been taught by Michael Laverick. So let's look at a deformity in a day-to-day practice. Post-trauma, how we do it: you put two lines in the center of the bone, you come out, you look at it, yeah, that's the problem. And this is how we sort it out. The problem is, if we do this thing, we always miss out on hidden deformities, particularly when they are periarticular subtle deformities. Now, this is another example which I'm going to show you now, and we'll go through it at the end of the talk. So if you do a simple anatomical line, it looks like that doesn't appear to be any of its deformity in the femur. Tibia, it's a bit of valgus, so you draw proximal line, distal line, and this obvious apex at the cora, and this is a deformity. We know that. Now let's think differently. Let's look the whole thing from a totally different perspective. So let me introduce some basics to you first. So a mechanical axis is a straight line which connects a center of two joints, center of the hip to the center of the knee to the ankle, whichever two joints. Anatomical line is a mid-diaphyseal line, and it doesn't have to be straight because it is a mid-diaphyseal line, and it follows the curves of the bone. Femur has a different mechanical and anatomical axis, and it subtends the angle of about 7 degrees, and the anatomical axis comes out slightly medial from the center of the femoral condyles. And it's typically when you do hold to do a total knee replacement for intramedullary jig, you don't go in the center, you go slightly medial. That's where the anatomical axis comes out. If you look at tibia, tibia has more or less parallel anatomical and mechanical axis, and for all practical purposes, we consider is one and same. And the same thing, you can look at the axis in the sagittal views. Now, if we have to correct the deformity, we need to analyze it in a way so that we analyze it properly and consistently each time, for which we need to have proper x-rays. That's very critical. And the way to do it x-rays, that we need to do a patella forward. Forget the foot, forget everything else. In a simple day-to-day practice, patella forward, and then do the x-ray. Patella for anterior, as we say it. And this is an example. So if you say in this example, there is a deformity, and there's clearly a valgus malalignment, but you look at the patella, it's a bit out. It's not in the center. You do another x-ray with the patella center, and suddenly you find your deformity is much worse than what originally we thought about. Now, if you correct the deformity from the first x-ray, you will undercorrect it. So therefore, you need to correct the deformity from the second x-ray with the patella anterior. And each time you correct it and measure it, you have to do the same way. So this is post-op, and these are the final pictures. Now, there are a number of angles which I'm sure all of you are familiar, so I won't go into detail. And there's a mechanical and anatomical landmarks and angles measured accordingly. This is in the coronal plane or frontal plane, and this is the sagittal plane. Now, let me introduce a few terms as well. So what is a cora? Cora is the rotation of angulation. Now, this is a term coined by the Japanese surgeon, and principally what it means is, if you draw the proximal segment axis and the distal segment axis, where it meets, that's what is cora. As compared to eka, eka is where you correct your your angulation. Now, it doesn't have to be the same. It can be different from osteotomy or the cora itself. If you look typically in a Lazarov frame, where you put your hinges, that's your ACA. So you can move your hinges up and down, and your ACA moves with the hinges. And similarly, you don't have to have the hinges. It is where you put your force when you correct a fracture in the in a child with a deformed bone. You put your two thumbs, and similarly, that's what it is in a day-to-day practice. Now, if you look at cora, we as a surgeon have no control of the cora because that is a geometrical thing which is we have no control over it. However, we have some control over the ACA and where we cut the bone, the osteotomy site. It is the relative position where you put each of these which will influence the final position of the bone segment, and that what you get at the end of your correction. So let me just run through quickly with the osteotomy rules. So rule 1 is when you have the ACA, the cora, and the osteotomy site at the same point, and if you correct everything at the same point, then it will align the bones with no secondary translation. This is an example. Advantage, since there is no secondary translation, we have no problem. We can use any implant we want. If you look at the rule 2, here the ACA and the cora is at the same level, but the osteotomy is a bit away. So what you get is you get slightly zigzag bone, but the overall alignment of the axis of the bone is spot on. And where is it useful? Somewhere like this. There's a high malunited fracture. You look at it, the angle PPTA is 94, which is clearly abnormal. You draw a normal angle and suddenly you find cora is very high. If you cut the bone there, you cannot fix the proximal segment. So what you have to do is you have to move your osteotomy down. When you move it down, use the rule 2 with a bit of translation. You correct the deformity and with a normal axis. So rule 2 is quite useful in the periarticular deformities and there's a compromised soft tissue or bone and you to move your osteotomy. The downside, you may be limited in your implant as you can't use your every implant. Certainly in diaphysis, you cannot use a nail because there would be translation. Osteotomy rule 3 is actually often a complication, though it can be used as an advantage by the surgeons. Here, the cora is different to the osteotomy and ACA, and therefore you end up with a secondary translation deformity. So the axis is parallel, but there's a secondary translation deformity. So when we plan the deformity, what I'm going to do is I'm going to introduce few sequential simple steps to help you with it. Now, before you move there, we need to decide what axis you're going to utilize to correct the deformity. As we know, there is an anatomical axis and there is a mechanical axis. In tibia, it is the same, so it makes no difference. But in femur, you cannot mix them. If you mix them, you will get disastrous results. You can choose whatever axis you want to correct the plan and correct the deformity and use the same axis all the way through. So step 1 is always you draw a line from the center of the hip to the center of the ankle, and the line passes either from the center of the knee or a little bit medial. Up to 10 millimeters practically we consider normal, up to 15 is suggested to be normal. Anything more medial is abnormal and anything lateral is abnormal. So if you have to take simple steps, I'm going to just run through simple steps. So this is a simple step for the anatomical axis planning. So first step is you measure your mechanical axis deviation. It is the transverse distance between the center of the knee to your line which you have drawn from the center of the hip to the center of the ankle. The next thing you do is you measure anatomical lateral distal femoral angle. Then you measure medial proximal tibial angle. please remember that the anatomical and mechanical angle is the same in tibia. Then you measure your joint line congruous angle. If there's any problem within the joint, is there any intra-articular deformity? Then you measure your medial proximal femoral angle, and you measure your lateral distal tibial angle. If you're using mechanical axis, the only difference is, rather than anatomical lateral distal femoral angle, you use mechanical lateral distal femoral angle, which is 88 degrees as compared to 81 degrees anatomical angle. And you have to measure lateral proximal femoral angle. Now, these are the simple steps you use each time you do the deformity planning. So let's run through an example with the femoral deformity analysis. So you put a point, center of the hip, center of the knee, center of the ankle, draw the line, and the transverse distance from the center of the knee to this line is your mechanical axis deviation. If it's within 10 to 15 millimeters, it's normal. Anything over is abnormal. Then you draw mid-diaphyseal femoral line and mid-diaphyseal tibial line. Then you draw your medial proximal tibial angle, which is normal in this case, 88 degrees. When you draw lateral distal femoral angle, we realize it is abnormal. Now the options we have is we can draw the angle from other side, whatever the angle from the other limb. If that is not available to us, or it's abnormal, then we can use the population average, which is 81 degrees. You draw an angle to 81 degrees, and you find where the two axes meet is the cora, and then you measure the magnitude of the deformity. In the tibia, anatomical and mechanical axis is the same, but we tend to use more mechanical because it's much simpler and it's much easier when the segments are small, and particularly when the deformity is very close to the joint. So we'll run through an example of a mechanical axis planning for the tibia. Again, step one, you put 3 points, center of the hip, center of the knee, center of the ankle. You draw a line, and then you measure the transverse distance, which would be your mechanical axis deviation. Then you draw mechanical lateral distal femoral angle, because we're doing mechanical axis planning in this case. Then you draw a line from the center of the knee to the center of the ankle, and you realize your medial proximal tibial angle and your lateral distal tibial angle both are abnormal. So what you have to do is we have to draw a proximal tibial mechanical axis. So as I said before, you can measure from other side. If other side is normal, you can do a population average. Or the third thing you can do is, if the femoral lateral distal femoral angle is normal, you can just extend the line. Or if you're not sure, then just draw a medial proximal tibial angle at 87 degrees. That will give you the proximal mechanical axis of the tibia. Then you draw a distal mechanical axis of the tibia, which is 90 degrees to the tibia, to the plafond. And you see both the axes meet at the apex of the deformity, which is your cora. You measure the deformity. Now, the important thing here is whether you do the mechanical axis or you do the anatomical axis, the magnitude of the deformity will stay the same. Now, I'm going to introduce another concept, which may be familiar to a lot of you and may not be to some of us others. So if you look at this deformity, there's a 30 degrees of varus and about 15 degrees of procurvatum. Now, a lot of people will think it's a two-plane deformity. In fact, it is a single plane deformity. The plane of the deformity is an oblique plane, and since we do the X-rays in AP and lateral view, which is a standard practice, it looks like it's a deformity in two planes. So how to analyze it? You can do a geometrical method, which is accurate. Even a graphical method up to 30 degrees is pretty accurate. So we look at the apex of the deformity. It's the left leg we are looking at it. So we put 1 degree equal to 1 millimeter for this method. We mark 15 millimeters with the anterior apex and the 30 degrees with the lateral apex, because it's a varus deformity. And we draw a vector. The length of this vector is the true deformity. It is actually 34 degrees, not 30 degrees. And the apex is anterolateral, and the direction of the deformity is 23 degrees to mediolateral plane and 67 degrees to AP plane. So it is a uniplanar deformity. If you correct the deformity in that plane, you will correct, you will put your hinges or whatever method you want to correct with a plate or an osteotomy, you will find that in the X-rays, it corrects both an AP and lateral plane. So just to revise what we have gone through, the first step, measure your mechanical axis deviation, measure lateral distal femoral angle, whether it is anatomical or mechanical, whichever axis you're using. Measure your medial proximal tibial angle, it is the same for both axes. Measure your joint line congruous angle, measure your lateral proximal femoral angle or medial proximal femoral angle, depending on whether using anatomical or mechanical axis. And you measure your lateral distal tibial angle. So each time you measure, you follow these simple steps, and you'll never miss a deformity. So let's go back to our original X-ray, which I showed to you. So I'm not going to go through full steps because we don't have enough time. But if I draw the angle, we realize that anatomical lateral distal femoral angle is about 75 degrees. There's a valgus in the tibia, so we draw the medial proximal tibial angle at 87 degrees, lateral distal tibial angle at 80 degrees, and we realize the cora is outside the bone, which means there's more than one deformity. So what you do is you draw a third line. But the important thing to realize in this case is, I haven't talked about the multi-apical deformity, so don't worry about that. But there's a two-level deformity in tibia. And the important thing is, if you do the conventional planning, you can easily miss distal femoral and distal tibia deformities because they're very subtle and can be easily missed. And therefore, I urge you that each time you plan a deformity or analyze a deformity, follow these simple steps. So to summarize, you have anatomical and mechanical axis. There's a planar deformity, direction, magnitude. There's a level of deformity. It can be uniapical, or there can more than one apex of the deformity. It can be extra-articular or intra-articular. You have a bony deformity, and there can be a soft tissue component of the deformity. And we have to take into account the soft tissue component of the deformity whenever you correct the bony deformity to ensure that you get full deformity correction. Your X-rays are critical, and you must do the X-rays in same way every time, otherwise you end up undercorrecting the deformity. For all deformities analysis of the deformity, simple plain X-rays are enough. That includes your rotational deformities. I never use a CT, and most of the limb recon surgeons don't use a CT because you can analyze and correct all deformities by simple plain X-rays. They appear complex, but if you use a simple sequential steps as I've suggested, is unlikely you will miss any deformity. There's always a soft tissue component. Just keep that in mind. And preoperative planning is crucial. Now, you may not have you may have a dedicated expensive software, you may not. If you don't have it, print the X-ray, draw some lines, take a pencil and a pair of scissors, some sticky tape, and you can do the exactly same job. And if I've enticed you enough, please do come next year at Hull for our next deformity course. Thank you very much.
That's awesome, Hemant. Thanks very much. That's brilliant, brilliant. I think I'm almost close to understanding it now. When it's the deformities in one place, let's say it's a malunited fracture, do you find yourself usually making your osteotomy at the old fracture? What would make you not want to do your osteotomy at the old fracture site?
If it's a fracture treated, means it's a virgin territory. So for example, it's treated in plaster and is malunited, then it's not a problem. However, you will find often they've had a previous plates or a nail and a bit of infection and a bit of scarring. In that case, it's much easier to move away in a in a good quality bone and soft tissue, use the rule 2 and get early healing and a good and equally good result.
Right. So it's, yeah, okay. So it's often a soft tissue consideration more than anything else.
Yes.
Nima, over to you, mate. What do you got in the Q&A?
Hemant, thank you very much. One of the questions that I wanted you to sort of talk us through a little bit is about deformities in patients who have arthritis. So let's say you have a 50-year-old man. He's had a previous tibial fracture. It is in something like 15 degrees of valgus, let's say, and he's now got knee arthritis. What are your sort of, how do you think about dealing with that particular problem?
So I look at it, I treat valgus and sort of lateral and medial osteoarthritis slightly differently. Mm-hmm. If it is a lateral, then I'll try to correct the deformity, so bring the axis to the center and just leave it at that. Slightly overcorrect it, often go to the medial tibial spine. But in the medial arthritis, which is more common and we see in day to day, often you'll find if you correct the deformity, it doesn't, you get the bone straight, but there's a dynamic component of the deformity, which is developed because of the soft tissue contractions on the medial side, possibly. Also, because of the wear of the cartilage. So if you just simply correct the deformity, you would get the straight bone, but it will not do anything to the patient in terms of pain, pain relief. So what I tend to do often is ignore the shaft deformity, go proximal, and I overcorrect it and translate it so that I leave the bone slightly zigzag, but since I've overcorrected and offloaded the medial, so in the future they have a standard knee replacement when they need it without any problems, which will last them as long as a normal knee. Plus, there's a good chance, and a lot of my patients actually do improve pain, and pain is often eliminated for a considerable period of time.
Brilliant. So, I mean, I agree with you. I think correcting alignment, particularly for the knee in the young patient, is really the first step, isn't it?
Yeah.
Great. We've got some questions here about sort of the type of osteotomy that you would do in the tibia. What is your thoughts? Because I mean, you can get constitutional varus, but also you can get deformities in the diaphysis. And I think you've talked a little bit about how you would do it, but just sort of very briefly, how you choose your osteotomy, and do you use internal fixation?
Now, if I'm doing internal fixation, which often sometimes I do, particularly for femur, I'll always do internal fixation, post deformity correction. And whenever I'm doing internal fixation, and I plan it pre-operatively, if I get then I tend to do a dome osteotomy if translation not too much, because bony contact is fantastic, it heals better. But if I'm using an external fixation, then I don't mind doing an open wedge osteotomy and correcting it slowly, because non-union is not such a big issue.
Brilliant. Well, Hemant, thank you very much. And now it gives me great pleasure to introduce you David Goodier. David Goodier was my first consultant when I became a registrar. He's probably the reason I do limb reconstruction. He has a lot to answer for. The other thing is that David has been an examiner for FRCS Orth for 10 years. So he's going to deliver a sort of a talk which is really orientated towards the exam, particularly what he expects of an absolute star candidate. And he's going to talk to us about bone infection. David, thank you very much. And the podium is yours, my friend.
Thank you, Nima. Okay, so basically, I've been asked to talk about the management of osteomyelitis in 15 minutes. It's taken me about 25 years to get to this point. So as you can imagine, there's going to be some shortcuts and corner cramming. But again, you can ask questions in the Q&A questions. I'll try to answer them either afterwards if we get time, or not at all if we don't. So basically, the management of osteomyelitis. Osteomyelitis was a term coined by this chap, Augustine Deleton, from the Greek osteo, myelon, and itis, bone marrow inflammation. So we're going to talk about what is osteomyelitis, how we confirm it, how do we treat it, and don't be an ostrich. Now, ostriches get a very bad press. When danger approaches, they tend to lie down, and because their necks and heads are the same color as the sand, this rumor came up that they bury their head in the sand at danger. They don't. They duck out of the way to avoid it, and then they run. They are some of the fastest land runners in existence. They can outrun cheetahs over short distances, but packs of cheetahs tend to bring them down. If they do get approached by a predator, they will turn around and kick. But nevertheless, the view that an ostrich buries its head in the sand persists. What they do is they try to ignore it, then they run away. Both have the same outcome. The reason I'm mentioning this is when it comes to osteomyelitis, don't be an ostrich. Don't hide from it, don't run away, and certainly don't bury your head in the sand because it won't go away. So what is osteomyelitis? It's a bacterial infection of the bone. Now I say bacterial, occasionally it is tubercular, very rarely fungal, unlikely to be any other organisms. You can have recurrent multifocal osteomyelitis and other things that don't necessarily become bacterial, but the overwhelming majority are bacteria. And those bacteria have to get into the bone somehow. The most common cause, particularly in children and young adults, is haematogenous spread in the bloodstream to end vessels. It can come in from direct trauma, open fractures, surgery, or it can adjacent spread from relatively avascular areas. We've all seen calcaneal pressure sores run through, erode down to bone, and then they becomes infected by direct spread. And what is the problem with osteomyelitis? Well, the problem is you need well-oxygenated tissues to kill any infection. Your antibodies, your T cells, need to get to an area of inflammation to kill it. And for that, you need tissues with a good, well-oxygenated blood supply. It does not matter if you fill the bloodstream with powerful antibiotics with a very high Scrabble score with lots of X's and Z's and Y's in their name. If they can't get to the germs and your body's inflammatory cells can't get there, they will not be successful. I'll put this in brackets because we're not really going to talk about acute hematogenous osteomyelitis. That'd be an entirely separate lecture in itself, just to say this is a common thing in children. It happens in the metaphysis of long bones because the capillary loops at the end of the physis cause slow and turbulent flow. So not only can bugs wedge there, it's a relatively avascular area. And it's almost always a single organism, most commonly a Staph aureus. In people with sickle cell disease, it's commonly something different. There are other germs nationally and internationally, but it's most commonly Staph aureus, even in sicklers. And it can usually be treated by antibiotics as long as you get it early enough that it's not caused further dead bone. You might need a biopsy to confirm the organism, but if it's fairly early on, it is worthwhile treating this with antibiotics that are likely to be effective against staph, such as flucloxacillin. If pus builds up, antibiotics are not going to penetrate it because pus is avascular. So you might need surgical decompression if there is pus there. Vertebral osteomyelitis, again, we're not really going to talk about. It's usually hematogenous spread. It usually actually starts at disc and end plates and tends to erode the vertebrae afterwards. So you often see this involving two adjacent vertebrae, and then it causes collapse. TB is not uncommon, particularly in certain regions and certain ethnic groups, particularly in East London, where I've worked previously, and Nima and Pete both still work. And this can lead to a primary presentation with a myelopathy, vertebral collapse, even before any systemic symptoms whatsoever. Infected non-unions, again, this could be an entire 1 hour lecture in itself. And you've got to ask yourself, is the metalwork loose? Can the infection be suppressed until union? And are you being an ostrich? Are you fooling yourself? If you are fooling yourself, then call a limb reconstruction surgeon. As Nima will testify, nobody likes a limb reconstruction surgeon until they need a limb reconstruction surgeon. So what I do want to talk about is chronic long bone osteomyelitis. This is where you get a chronic bacterial contamination. By chronic, I usually mean a minimum of 2 months. You get this localized inflammatory response to infection. These polymorphonuclear cells release chemotactic factors that drag in more PMNs. They increase local blood flow as the inflammatory reaction takes place. Now that local blood flow and inflammatory reaction causes a swelling. This kills some bacteria. They're taken out in a sea of pus, and they cause local bone reabsorption, both by the increased blood flow itself washing out the calcium, but also by the PMNs having a relatively bone eroding function. This is before any activation of osteoclasts. This is purely a local inflammatory reaction leading to local bone resorption, heat, swelling, pus. That pus in bone will tend to work its way through the low pressure channel towards the periosteum, where it can elevate it and even break out of it. Now again, areas of relative avascularity are relatively protected from these cells because they don't have the blood flow to get these cells there. So because these areas of relative avascularity are protected, the bugs that are there can retreat. They can form enclosed colonies. They can form biofilms on either necrotic material or artificial material. And once they form these Glycocalyx-enclosed colonies, it's very difficult for the host immune response to eradicate them. And these relatively poor areas become necrotic due to lack of blood supply. And that's what a sequestrum is. It's a necrotic focus of dead bone. So what your body does is on the surface where it's very active, it lays down inflammatory tissue, which becomes through the various stages of granuloma through to bone. So new bone gets laid down on the surface of these necrotic areas. And this is what involucrum is. Just a little word about these Glycocalyx-enclosed colonies. What actually is happening there is you're getting your bacteria dying. They're undergoing apoptosis, and as they do, they exude this exopolysaccharide. The bacteria themselves enter this sessile phase where there's no active growth. And the problem here is that a huge number of antibiotics actually target bacterial replication. So if the bacteria have gone into this sessile phase, they're not replicating, the antibiotics are not going to be effective. Other antibiotics actually affect the metabolism of the bacteria themselves. But because they're going into this relatively sleepy, low metabolic phase, these antibiotics are also fairly ineffective. So you get these colonies that are physically barriered by the exopolysaccharide. They're not replicating as the antibacterial replications aren't in, and with a low bacterial rate, other antibiotics aren't effective. So you end up with these colonies that secrete more exopolysaccharide. And if they're on a surface, for example, on bone or sequestrum necrotic bone, they form these biofilms, but they can also form little islands of Glycocalyx-enclosed colonies that aren't necessarily on a surface. They can be sitting free in apparently normal bone. And that is one of the problems. That is why, unlike true love, osteomyelitis can be forever. There can be isolated colonies of bugs existing there completely undisturbed until you go and disturb it months, years later. And the interesting thing is when we start looking at these biofilms and colonies, there are little channels within that allows communication between these bacterial colonies. And there are signal proteins that travel along these channels, which change gene expression in bacteria themselves. For example, a thing called quorum sensing, where the bacteria remain sessile and inert until they feel there are sufficient numbers between them from sensing along these channels. Then all of a sudden there are released toxins that will create a local host response and allow them to multiply further. And weirdly enough, in the papers last week, someone's actually found a way of dealing with these channels, which may actually be able to fool the bugs themselves and cause them to replicate to make antibiotics more effective. It's one of the first breakthroughs in antibiotic use for the last 20 years. And that's hot off the presses in the papers last week. This dormancy may continue for years and years and years. What's the question? Well, once you've got this avascular tissue, eradication is highly unlikely. And therefore, you often need operative debridement. And that includes any foreign bodies, including metal, plates, dead bone. If you don't, then reactivation can occur pretty much any time. It may be a temporary reduction of host resistance status from a concurrent infection, dose of the flu or COVID, decrease your immune response, causing a change in the host immune response. Local trauma, even spontaneously, you can get reactivation. You can suppress it again, but you may get these cycles of activation and remission, leading to a gradual increase in the amount of dead bone and increase the amount of surrounding involucrum. How do we classify it? Well, we can classify by presentation, acute, subacute, chronic, by method, either haematogenous, exogenous, contiguous, like I said, by pus formation. The overwhelming majority are suppurative, but you can get things like sclerosing osteolytis and Garay's disease, which don't form pus, or by anatomy and physiology of what's actually happening there. And this is where Cierny-Mader comes in. This is quite a common exam topic, Cierny-Mader. It's either the anatomical location within the medulla, on the surface, localized full thickness, or diffuse, and the host response, a normal host, a host with local compromise, systemic compromise, or such bad compromise that the morbidity of the treatment will be worse than the disease itself. So it's either here, purely medullary, here, purely superficial, where it's not through the full thickness of the cortex, here, where it is through the full thickness of the cortex, but it's local, or here, type 4, where the sequestrum involves a whole segment of bone. The systemic factors, malnutrition, renal failure, diabetes, are the usual suspects. The local factors, local blood flow, venous stasis, major ventral compromise, osteitis, local scarring, either from previous disease, radiation fibrosis, and tobacco use, which is probably both systemic and local. Diagnosis of osteomyelitis, well, this is back to medical school, history, examination, specialist investigation. There may be little other than pain, swelling, all the way through to persistent intermittent discharge. Culture pus is probably not useful. It's usually polymicrobial, except in the case of acute. In the chronic form, it's very rare that you get a single organism. You may not actually grow the original bacterium, which may be hiding at the bottom with a super added staphylococcal on top, for example. Plain radiographs, well, they may show things ranging from a Brodie's abscess to lucencies to a periosteal reaction all the way up to sequestrum. So, for example, this chronic inflammatory reaction with a sclerotic margin and a hollow core, this is a classic Brodie's abscess characteristic of chronic osteomyelitis with the reaction around it. This is what erosion looks like in a fifth metatarsal. It's actually neuropathic ulceration over the head of the fifth metatarsal that caused contiguous spread of osteomyelitis to the fifth MT head. Periosteal reaction, the distal tibia here with a raised periosteum and infection bursting out there. This was actually a previous fracture, but this became infected. There's a chronic increasing reaction there. And this is the case I put up as the test case. This is actually a sequestrum involucrum. This here is the shaft of femur that was fractured, had a stress fracture due to infection, and has been walled off by an involucrum. But that involucrum is incomplete in places. So if you wanted to take out that sequestrum, you'd be left just with a thin rim of involucrum. And that involucrum does not have the normal striated pattern of bone. It is not structurally the same. And because it's partially sclerotic, there may actually be infection within it as well. It's a difficult thing when you get this kind of area sequestrum over a significant length. Special investigations, CT scan may show you sequestrum. MRI scan. Now, MRI scan's interesting. If you've ever had metal in you, you will know from your basic sciences that all metals form a passivation coat on the surface. That passivation coat is designed to be worn away by the surface and reform to protect it. Therefore, if metal's been in long enough, you will have ionic metal debris at the site of anywhere you've had metal in for any length of time, particularly tibial nails. When you extract a tibial nail, an MRI scan will always show you a high signal in the T2 sequences from the ionic metal. Even if you cannot see any metal swarf on the X-rays, the ionic metal from the passivation coat will cause a high T2 signal in MRI. And the number of radiologists that will report that as, oh, infection, fluid, it is not. It is just a high residual signal of metal. You need to start comparing your short tau inversion recovery sequences, your stir sequences with your fat suppression sequences, with your proton density sequences, and see what is actually free fluid and what is likely to be metal. So it's a tricky one. Nuclear medicine scans, technetium 99 is often useful. We can label white cells very easily with indium or HMPAO. But again, these are very sensitive, but not necessarily very specific, which means that if they're negative, it's great news. If they're positive, though, it doesn't necessarily differentiate from remodeled fracture and infection. What is much better is both sensitive and specific fluorodeoxyglucose positron emission tomography CT scans, FDG PETs. And these are actually very, very good scans, and I use a lot of these if possible. They are, however, rather expensive, but luckily I don't care. Treatment, Cierny-Mader 1, well, you've not got any significant thing outside the medulla. You might need to drain it, but usually trial of antibiotics. If it doesn't work, open it up and debride it, either by a window or ream it out of its diaphyseal. You can put some calcium beads in, exuding local antibiotics. I'm a big fan of Stimulan because it disappears. Oral versus antibiotics. There was a recent trial, the oral versus intravenous antibiotics in chronic osteomyelitis trial, which showed that oral antibiotics are as effective as intravenous antibiotics in a sensitive organism. An 85% likelihood of cure with CM1. If your blood culture negative, you can't really find out what the germ is without opening it and taking biopsies. You might as well take the chance to debride the cavity and wash out, start something broad spectrum and wait till you get a germ. CM2, it's on the surface. As previous, you scrape away the surface, but you need to consider coverage. And because the area might be the surface of the tibia and the midshaft, it's often tricky without things like local flaps, rotational flaps, or even free tissue transfer. And then you're faced with the question is whether you do it single stage and leave this uncovered until you know you've got everything. Multiple stage would leave it uncovered, or single stage you actually cover and go. A lot of evidence that says if the debridement's done properly, it's a bit like doing open tibial fractures. If the debridement's done properly, you can do a single stage clean out and flap coverage. If there's no coverage option and you're 80-odd-year-old, Well, you can consider old style treatments like the Papineau technique, which is in the books. CM3, as previously, but debriding full thickness of cortex, which leads to the high risk of fracture. Splints are difficult because they've compromised the wound, so you might need protective external fixation, or you can use a more structural calcium hydroxyapatite mix for cortical defects such as cement G, or you can leave it with an X-fix, debride it, and put some bone graft in later. You don't want to put bone graft in at the time because it's just sequestrum, really. CM4, this is where you've got segmental, full thickness, full cortex defects. Now, this is where you start thinking about suppression if you've got an involucrum. If you're going to suppress Staph aureus, then you're probably going to be looking at long-term intermittent use of doxycycline, or doing something brave. Chop the whole area out and do a Lisroff reconstruction, which Nima is going to talk about shortly. And in people with vasculopaths and diabetics, amputation is a very real possibility and a possible outcome. So just briefly, I'll go through the case I did earlier. I put up, this was a 49-year-old male in 2012. I saw him, he was 28. At the age of 28, had a left open femur fracture, managed conservatively with local drainage and periods of antibiotics, and presented me with a foul-smelling discharge, 5 times the dressing changes, and wanted his amputation because the family couldn't stand the smell. He was a non-smoker, no comorbidities, and he's had limited quads due to his quads being adherent. And these are his x-rays. As I said, this is entire segment of dead femur. Now, the problem here is that when you look at the CT scans, the involucrum has holes on front, back, and sides of it. The involucrum itself is not structurally sound enough to manage debriding that away. So the easiest thing to do in this circumstance is go, well, that whole area needs to come out, but unfortunately it leaves a hole that's an extremely tricky resection. Now, Nima's going to talk about this shortly, but I'll just steal his thunder to say, yeah, we chopped out 21 centimeters of femur, opened up that involucrum and found his dead previous femoral shaft, and chopped it out. As you'll see, I've left him fairly short to start with, done a corticotomy, lengthened him down, then lengthened him back, but this started getting a bit weak, and you can see the bow on the upper pins here. Those upper pins went on and fractured, so they got repositioned, and we didn't get any more length. We just left him short and healed. But once it had healed, because we know this is now sterile, you can take these pins out, put a precise nail in a couple of years down the line, and give him his length back. And he's quite happy with that. So that was a good result from someone who's having 5 times a day dressings for stinky discharge. But it does take a certain amount of colonies to say he had chronic osteomyelitis. I'm going to put metalwork in him and do a precise nail lengthening after transport. Anyway, that's pretty much all I'm going to say on the subject. Back to Q&A.
Dave, I love it. So what you basically presented there in terms of treatment is a huge range, going from like taking out a small area infected bone right the way up to chopping out massive segments in 2-3 years worth of treatment, slowly getting back to a leg that's functional. At what stage in that does someone like me, like a jobbing orthopod, refer those cases on?
Okay, so it's long been a bugbear of mine that there are some people who are happy to do local debridements and antibiotics as long as they're dealing close with their orthopedic colleagues and their microbiologists specifically. I think that's great. I think it should be within the armamentarium of any orthopedic surgeon to deal with an initial debridement, wash out, antibiotics, see how the results are. If that happens time and time again, i.e. sort of multiple recurrences, then you're faced with a choice of either, well, I've got to take more out, or it may be, once every 5, 8, 10 years, in which case you're happy to do it. If it's close to joints, it's a lot trickier, but you have to have the self-confidence to be able to do an adequate debridement. And that often means going out where the hole is in the back of the femoral shaft, next to the sciatic nerve, or guddling around to the medial side where there is that, or in the tibia and fibula where you might be causing secondary compromise. But if you have those surgical skills, and most people have, then that shouldn't be a major problem. So I think that the majority of osteomyelitis should be managed by an ordinary orthopedic surgeon in a DGH. Pediatric osteomyelitis is subtly different because, again, it's something I didn't want to touch on, but as we're here, if it is periarticular, you often have the big question of you have a reactive effusion in the adjacent joint. You're pretty convinced this is metaphyseal osteomyelitis. If you open the joint up, you stand the risk of transferring infection into a previously sterile joint. If you don't, you have the chance of missing a septic arthritis. I say these are questions you can go into a whole world of hurt about. And at those, I'd get the opinion of a pediatric orthopedic surgeon at the drop of a hat. Again, if you're pretty confident it's just localized, then yeah, there's no reason why an ordinary jobbing orthopedic surgeon can't drain that by drill holes, wash out the pus, blah, 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 particularly in the middle of the night when the patient's in extremis. So there's the emergent management of the acute, there's the management of the chronic with it's just a debridement. But once you start getting to multiple debridements, particularly if you've got a big involucrum that might risk the structural integrity of the bone, I think it is better to have the confidence, balls to take out a segment of bone and get rid of it than keep going with multiple debridements, ending up with a poor outcome for the patient.
Yeah.
Bottom line is, don't send me all your osteomyelitis, please.
Tell me about microbiology quickly. I get the impression that from hearing you that the pus swabs that you might take, like there's pus pouring out of the leg, you take a swab, that's going to be full of all sorts of bugs that have colonized that tract. How often is it that the actual bug inside the bone is polymicrobial? Or is it almost always one bug?
It's almost always a single bug that you don't always necessarily grow. There's a lot of evidence that these things that we considered previously to be sclerosing osteitis or, non-bug osteomyelitis is actually, when you do specialist growth medium, you get all sorts of rare germs that may have kicked off an inflammatory response, led to a bit of relative avascularity that opportunistic staph has dived into and secondly contaminated. And then once it forms a chronic ulcer, you get your E. coli contamination on the mouth. So it's often polymicrobial, of which the initiating cause is often something quite unusual. It's probably anaerobic in a lot of cases if it's a rare bug that you find it difficult to eradicate. And of course, the majority, you're growing the staph from the stuff that's pouring out. So you kill that off and then you wonder why you don't cure it. It's probably because you've not done the specialist cultures deep down. So advice from your microbiologist about what's going around, your Salmonella typhi and your Sicklers, your odd weird things in people who are immunocompromised, your resistant TB in your HIV population. It's a changing field and you really do need a microbiologist on board to deal with it.
Yeah. And the other thing I'll just add to that is that it will be a good practice not to give antibiotics at least a couple of weeks prior to surgery.
Absolutely.
And your chances of growing any bug increases significantly. And it helps you tremendously in dealing with the infection.
Yeah, I flashed it up on the slide, but basically if you've got a positive blood culture, it's very likely to be the infecting organism. If it's negative, you're going to do biopsies. Don't give them antibiotics until you know what it is. Now, weirdly enough, once you've taken them to theatre, there's always this question of whether or not you give antibiotics with induction or whether you take the samples first and then give antibiotics. Actually, it's work from Oxford showing that the the 45 minutes until you get these samples is probably irrelevant. So you can give them. I mean, let's face it, if 5 courses of 6 weeks of antibiotics haven't eradicated it, 20 minutes of antibiotics are unlikely to significantly alter it in that timescale. Yeah. But it may have been suppressed if you've been given it a week beforehand. So not giving anything unless it's going to jeopardize their physical welfare for 2 weeks is probably a good plan.
Nima, over to you, mate.
Brilliant. Well, David, thank you very much for that. Again, we can sit here and talk about bone infection for hours, but we won't.
I see.
I need a drink if we are.
So one of the things that I wanted to ask you is the question around single stage surgery versus staging it.
Yep.
What are your thoughts on that? So just a brief thing, and then there are some questions on the Q&A that I'll leave you to answer.
Interesting one. There was, bizarrely enough, 2 weeks ago, I'm not sure if I'm allowed to say this, I reviewed a paper for the Bone and Joint Journal, which I recommended publication of, which is looking at single stage debridement, flap coverage and Ilizarov reconstruction with segmental transport for some osteomyelitis and single stage Ilizarov flap and not transport, but bracing it for those who have had a partial defect. And their results are excellent. As part of that, they did a literature review on the single stage versus multi-stage, and actually most of big units that have the confidence are moving towards single stage, including Martin McNally and Dave Stubbs at the Oxford Bone Infection Centre. So if you have the confidence of the debridement and you have plastic surgeons who know where the sink is in theatre, you generally do all right. But it's a bit like doing the flaps for doing the flaps for open tibial fractures, you need a plastic surgeon who understands what you're thinking. You need to know where you're coming from, microbiologist involved, and if all the ducks line up in a row, then it is safe to do a single stage debridement and coverage. I mean, the other alternative, you leave them open to the air for a couple of weeks while they have photography under anaesthetic, PUA, by the sort of, the junior plastics team until they think it's ready for coverage, by which time you're a bit worried because those tissues that were beautiful in the debridement are a bit dry on the surface, they're a little bit contaminated possibly, and then they get a flap.
Agreed. I think, I mean, you've hit the nail, for me, you've hit the nail on the head, is actually having the confidence to do the debridement, and actually secondly to have the skill set to be able to deal with the defect that's left behind.
As Dave pointed out, I think if you have an MDT or you have a team, then I think all units in the country are moving, have gone to single stage. I mean, unless there is a reason not to do, the standard of care should be a single stage management of the osteomyelitis.
I mean, if you wanted the postgraduate question, that revolves around, if you're putting a free flap on, should it be a fasciocutaneous flap or muscle? There is some evidence that muscle actually has an active scavenging role and can actually cause further debridement over and above a fasciocutaneous flap, but that's a bit here saying there's no cast iron evidence at the moment. But that's at sort of the bleeding edge of thoughts at the moment.
Brilliant. Well, thank you very much, David. What I'm going to do now is I'm going to, now that David has debrided the bejeebers out of the bone, what do you do to fix it? So I'm going to talk a little bit about bone loss and how we deal with that. So the aims of my talk really are to give you an awareness of the techniques available. What are the things that we can do to deal with bone loss, and actually in a lot of patients you may have to design quite a bespoke treatment for them, because you have to make it fit the disease and actually the carrier of the disease, which is the patient. Broadly, defects fall into two categories. So here on the left, we've got an open tibial fracture, and that bit of cortex may well be completely devitalized and may end up in the bin after an appropriate debridement. And that's called a partial defect because the portion of the cortex still remains intact or in continuity. The other one is a segmental defect, where an entire section of the bone is missing, much like the case that David showed you in the femur. The strategy to deal with partial defects can be a number of different ways. You can either retain fragments and internal fixation. I'm going to talk about that a little bit. You can discard fragments and go on to internal fixation. That is the standard of care. And you can either bone graft immediately or in a delayed manner, depending on the etiology of the bone loss. So the idea of retaining fragments and fixing internally was brought about by a group in Bristol, my colleagues in Bristol, and they've been doing this from 2014. And here is a picture of the case from their paper, where you've got a tibial fracture, you've got a cortical fragment which is completely devitalized. This is taken out, it is fully debrided, then it's actually put back in. The tibia is nailed. You can see here the supplementary fixation to allow the retention of this fragment, which is thought to be mechanically important. And here is their results. They had 113 patients, 44 patients' bone was replaced, 69 were controlled and were not replaced. And here is their complications. So they had 3 patients in the retained section where they had complications of requiring either revision of the internal fixation or revision of the soft tissue work. Now, the thing that I would say about this is that we have to be quite careful with regards to what we take away from this paper. What they have said themselves, the take-home message from their unit where this is practiced, is that you should have an orthoplastics unit. It is an MDT. It's a combined approach between the orthopedic surgeon and the plastic surgeons. And it is combined decision-making. You have to have immediate soft tissue cover. You have to have surgeons who are used to debriding open fractures and have the confidence to be able to do it well. So I think this is not something to be done by anyone who has come across an open fracture, but you have to be quite confident and actually have the capability to be able to dig yourself out of a hole should you find yourself in there. Here are occasionally what you may have are unusual problems. Here is a case of a 24-year-old man. Cyclist was dragged underneath the truck. He has an isolated injury with, you can see, the vast majority of the distal tibia and the talus have been essentially scraped off by the road. Here is a sort of a nice three-dimensional CT scan to give you an idea of what the defect actually is. Now here, a partial defect after debridement, this is what it looks like. It has been temporized, and after it's been temporized, we had a long discussion about what we could do with him. And at 72 hours post-operatively, we went back. I have prepared his ankle joint for fusion, and thankfully there is an extra little bit of fibula which is shaped exactly like the segment of bone which was missing. This has been positioned, temporized with an external fixator whilst the free flap matures, and then converted to a circular frame, and he has gone on to unite. The take-home message from this one is that it's important to utilize what you have to hand. Spare parts surgery is important. You know, there are things there that you can use. Have friends, such as good plastic surgeons, that can cover the soft tissues. And if possible, choose a patient who is young and has got good physiology and will probably heal despite your efforts. Talking about segmental loss. Now we're going into an area where there is a lot of missing bone. And the concept here that I want to introduce is one of critical size defect. A critical size defect is one that will not heal spontaneously, but without bone grafting. And there is no really a consensus on what size of this defect this should be. I think it requires, it is associated with a number of different things. It depends on the age of the patient, on the comorbidities and local factors, particularly the soft tissue cover and the vascularity. A femoral defect of several centimeters will probably heal in a 15-year-old or a younger child, but in someone who is in their 50s who smokes will definitely not do so. There have been some data on what this means. So the SPRINT trial was a trial conducted in multiple centers comparing intramedullary nailing reamed and unreamed in open and closed tibial fractures. And what they found is that what they decided to call a critical size defect was more than 1 centimeter in length and more than 50% of the cortical diameter. But by those estimations, 47% of those 37 patients that actually came within that bracket went on to heal. So 50% of these critical size defects went on to heal. And they actually talked about there needs to be more work done in this. Here is another paper by a group in the US, and they decided to try and quantify how you measure this bone gap. And here it is. So basically you take an AP and a lateral radiograph of a tibia. You measure the gap in the cortex, both medially and laterally, anteriorly and posteriorly. You add all of these things up, and then you divide it by 4, the number of cortices, and the number that you come up with is the radiographically apparent bone gap. And here it is. So, and this is the group that went on to union and non-union. So the top line, the blue line, are the ones that went on to unite. And you can see that all of them were below 25 millimeters. The red line that extend up to 45 millimeters, they tend to go into non-union, but even some very small gaps go on to non-union. So the answer still remains not quite apparent, but some bone gaps do go on to unite. So what do you do with segmental loss? And I'm going to talk through a number of strategies, and they depend on a number of factors, particularly patient-related ones. So shortening is one. Here is a young man run over by a bus, had his ankle fixed Unfortunately, everything broke down. He had distal tibial infection, necrosis. The entire of the distal tibia had to be resected. He had quite a lot of challenges. He was educationally challenged, so shall we say, and could not adhere to any instructions. So we shortened him. He's got soft tissue cover for the defect. He has been shortened. He's been put into a frame that allows him to bear load almost immediately post-operatively. He has gone on to heal. Despite there being lots of arthritic joints around the ankle, he is now able to walk on it, and this is some 6.5 months down the line from the original operation. So shortening, particularly in the lower limb, is feasible, and it certainly is something to do in the upper limb for the humerus in particular. In the forearm, however, loss of length is an important thing that we need to try and correct. And here we are, a young lady who's had multiple operations for a forearm fracture and it's just gone on to resorption. It is not infected, but she has got a segmental loss. Intraoperatively, it's been debrided. We've held it out with an external fixator temporarily, whilst my plastic surgeons take a little bit of fibula and plumb that into the radial artery in her forearm. It is then fixed, and at some months down the line, these take an awfully long time to heal, and at 6 months it's still not united at the proximal end, but at 8 months it is united. She still has a short radius. We just couldn't crank it out anymore. She will need something doing with her distal radial ulnar joint, but that's for another day. So in the upper limb, free fibula grafting is certainly something to be done. In the lower limb, when you have segmental defects, there is a concept of distraction osteogenesis and bone transport. Here, you have a segmental defect, you mount a frame on the leg, you perform a corticotomy or an osteotomy proximally or distally, and you gradually drag the bone to generate bone in the gap that you are creating and obliterating the gap distally. This is called bone transport. And here is an example. This is a post-trauma loss of some tibia. So he's been shortened distally to allow apposition of the bone ends, and you can see a proximal corticotomy between the two rings, and he has been pulled out to length. The alignment has been nicely corrected, and then once it has reached length, we allow the regenerate to consolidate, and this recreates the tibia. One of the advantages of this technique is that it is reliable. There really is no limit to the length of bone loss that you can treat with this technique. And it does allow the patient to bear load immediately after the surgical intervention. The thing is, though, it is not really a free lunch. It takes a great deal of time. The treatment is complex, and the poor souls to whom this is done have an enormous physical and psychological burden, as well as a financial burden that they need to contend with. These patients tend to be young men of working age, and they are, they're really affected by this. So to try and mitigate some of those problems, one thing that has been developed is plate-assisted telescopic nail transport, and particularly for the femur. You can see this is what a femoral frame looks like. Horrible business. There is huge amount of soft tissue, and transfixation of this soft tissue against the bone to try and control it causes huge soft tissue problems. Patients hate femoral frames. They can't move their knee. Pin sites frequently get infected. So one of the solutions for this is using these telescopic nails, exactly the one that David showed for the residual length that he had to correct in his femoral osteomyelitis case. So here is an example of how we use it at the Royal London with the technique developed by my good friend Alex Vriss, who works with me in the unit. So he's a young man, has lost about 10 or 15 centimeters of his femur on the road. We temporize it with a internal fixation device and a large cement block to afford some stability. This is him at a few days down the line. He can already bear load on it because it's a stable construct. We supplement the lateral plate with a medial plate, remove the polymethyl methacrylate plug. We put a pre-extended nail into the distal femur, corticotomy above, and here we are, retrograde transport. So we are now shortening the nail in order to drag this segment down distally. And we bring it down to dock, and once it's docked, you can cross-lock it through the plate that is already there. And at 16 months down the line, he has essentially a reconstructed femur. It is a lot of metal work. He has required a number of surgical interventions, but the key thing here is that femoral transport is not for the faint-hearted, particularly for the patients. And this does allow the patient to bear load on it, and he doesn't have the pin sites and the external fixator to contend with on his femur. There is also the possibility of using some 3D printed cages to deal with bone loss. And here is a case, distal tibial fracture. You can see the 360-degree plating of the distal tibia. He has required one revision plating and bone grafting. He's still having difficulty in walking. You can see the metalwork is gradually failing. So he goes to theatre, has all of it removed. Clearly, it is not healed. And actually, this is the quality of the bone when we remove the metalwork was awful. There is very little in the way of good quality bone in that distal tibia. And the reason those screws have been left behind is because the distal tibia is like toothpaste, and excavating that to try and remove those screws would have left him with a segmental resection at the metalwork removal. So what we did is that we discussed it with a company called 4Web that produce cages that we can replace it with. There is a lot of preoperative planning. We plan the segmental resection, and we then effect exactly that in an operating theatre. We design a cage that has a lot of structural integrity. This is used in conjunction with a retrograde hindfoot nail. And in the operating theatre, we have all the kit to essentially to play out the operation before doing it, and some molds to be able to make sure it fits appropriately. You can see here is the cage, which has been filled with both allograft and autograft from the posterior iliac crest, and then it's been implanted with a retrograde nail. Again, the thing with this chap is that although he's been non-weight bearing for about 5 months, and then in a plaster and an air cast boot, and it's taken some 7 to 8 months to get osseointegration proximally and distally, he absolutely refused to have a circular frame. And this provides a good solution, although we need more data. Again, you need to have a multidisciplinary team. You need to have people like plastic surgeons who can bail you out. So really, take-home messages for me is that surgery in these cases really is the beginning of the journey, particularly for the patient and for the surgeon. One thing that I haven't talked about a great deal, but is important to mention, that complex foot injuries below a complex tibial fracture carry an awful prognosis, and you should definitely consider amputation, and at least a discussion of this with your patient. And also remember, small bone gaps may heal spontaneously, particularly in a patient who is otherwise fit and well. Thank you very much.
Cheers, buddy. That was great. I love it. One of the things we can't leave. I can't help feeling if we were having this chat in the US, there will be definitely some discussion around masculae. Where is masculae right now? Nima, why don't you kick us off with that, and then we'll hear what the other.
I'll tell you, I mean, the thing is that masculae is very interesting when you talk to people who are not publishing on it, because there seems to be a general consensus masculae doesn't work very well in many hands. In my hands, I've tried it a couple of times. I just don't seem to make it work. One of the issues that I have with it is that the bone that you produce by masculae is not aligned. It is not mechanically strong bone. And also what seems to happen is that it sort of joins at either end, and then you get this fibrous non-union through the middle of it. And it maybe is my technique, but a lot of people have gone away from using masculae. I've certainly completely stopped using it, apart from maybe partial defects when there is already internal fixation device in.
And my experience would be, sorry, Dave.
Hemant, go.
Yeah, my experience is similar, that the other problem you'll find with masculae is that the bone grafts gets absorbed, and then you end up going and doing the bone grafts again. So to be honest, it is one of the techniques which I will use when there is nothing else is available, and certainly in the bone where there's a decent soft tissue cover. So upper limb for a small segments, it's rather than transport or lengthening, it works well because you clean it, put bone graft a couple of centimeters. I think it's okay. But for tibia, I haven't got any. I don't have any good results in tibia, so I practically have given it up again. Yes.
Okay, Dave.
I have views, unsurprisingly. So 197 participants are going to hear them. Basically, from a basic sciences point of view, it's witchcraft. Bone graft incorporation requires on capillary loops, blood gets in there by oxygen diffusion to about 0.2 millimeters of bone graft. Everything in bone graft dies. There are no living cells beyond 0.2 millimeters of bone graft surface. Everything else is bone morphogenetic proteins in your autograft dragging in capillary loops to revascularize it. This does not happen over large areas. It cannot happen over large areas. What we do know is if a femur fracture and you put an X-fix on it without any kind of bone graft, you quite often see reconstitution of significant defects in bone without any intervention whatsoever, just from residual bone dust and periosteum. What we do know also is that many people show lovely X-rays in tibias of masculae with a nail through a cage and supplementary bone graft, allograft and everything. I have yet to see anyone have the confidence to take out the metalwork and show me striated, remodeled bone in a significant masculae length. I've seen many people with a tibial nails still in going, look at all this bone. And what you see is whiteness and calcium. You do not see striated, remodeled bone, except in areas such as the femoral shaft, where you might see it anyway had you not interfered. I think this whole thing towards masculae was a very useful idea, but the two-stage use of acute shortening of the femur with secondary lengthening by precise nails or the new segmental transport nails mean the actual role for masculae has diminished to, in my opinion, absolute zero.
Great.
I agree. And I think what Nima pointed out very nicely was that the most reliable technique is hard work, is the lengthening or transport, whichever way you want to look at it with the frame. It is hard work with the most reliable technique.
Yeah. And going on that, and I know this is a bit soft and it's probably not what the technicians in the audience want to hear, but here's a question. I just want to hear your takes, various takes on how you prepare patients for this. Like Dave, you were discussing a guy there who basically ended up in a frame for like the best part of 2.5 years. Nima, that cage dude, that took a long time. The big segmental transports take a long time. How do you prepare people psychologically for this kind of action?
I'm in a very, very lucky position. I'm a limb reconstruction surgeon at the Royal National Orthopaedic Hospital, so everything I get referred has had a problem before. I'm not going to say cocked up, because a lot of it is well-meaning orthopedic surgeons doing perfectly adequate operations with a 95% cure rate, and I make a very good living off the other 1 in 20. You know, these are problems that have been going on quite often for some years in patients. I always sit them down and tell them how wonderful amputation is as the first stage. and how we might be able to avoid it if they're lucky, because no one wants to mention amputation, but every patient I have has spent nights awake thinking, oh my God, I'm going to lose my leg. Oh, am I going to lose my leg? When you sit down and tell them, you can lose your leg if you want, or you can suffer a year of treatment in this way, major form, it's great. Now, having said that, I'm moving away from frames and towards intramedullary nailing an awful lot. It's great, but there are some times when you have no choice, complex deformities, but they are the patients who have had complex deformities for many, many years. They've been neglected elsewhere. The case I showed, 26 years of stinking, fish-smelling, disgusting odor that made his family sick with 5 times a day dressings over the preceding 10 years. And he was too proximal for an amputation. He came to me saying, I've made up my mind because the last 5 surgeries offered an amputation. I want you to take my leg off. And I kind of went, well.
Could go on a 2-year journey together.
Weird thing is, by taking out his femur, it effectively gave me a quadsplasty as well. So his knee moves now. It's great.
Matt, tell me, what's your take on the psychology around these things?
Go on, Hemant.
Okay, so one of the things I do is I mean, the part of what Dave said is correct, that most of these patients are referred. So that's an advantage. Then multiple surgeries, they're unfortunate it failed. So you talk about amputation, they don't want an amputation, they want to keep the leg, so that's on your side. Other thing is that the first initial consultation has to be extensively detailed. And also, I do not put any complex frames in one go. They come to the clinic, have a discussion, they go to the team, talk to a specialist, nurse and physio, then they go on the list. And before the surgery, I see them again, all 3 of us again, just to make sure that they are adequately prepared. Despite all that, you lose patients at time. And from what we feel is that around about 4 months time, they all seem to lose a plot a little bit, in a sense they get depressed, things are not happening. And I think if you get through 4 or 5 month period, then usually they do fine, but it's pretty hard work. And most of the units will benefit from a psychologist, but none of them have it, or very few have it because of the lack of money. So you do a dual role of preparing, talking, but the best people to talk them is the Elizabeth nurse or the limb recon nurse and physio. They're absolutely brilliant. And the physio classes, with there are 20 patients in the class, works very well.
Absolutely. I mean, I've got to big up my frame nurses, otherwise I get shot. But you've also got to be able to tell them what the limitations of treatment are. I saw a bloke who was actually on telly last Sunday who had this horrendous deformity in his tibia. Basically, my conclusion was, don't have anything done. You've had enough surgery. It will just make you worse.
Yeah.
Nima.
I think the thing that my patients fall into 2 groups. A group that you can delay, and another group that have an obvious soft tissue and bone defect there and there on their tibia, right? So, and those ones, you don't have the privilege of being able to time your intervention. The thing is that the more I do, the more of a psychologist I become, and less the technical side doesn't challenge me. And it's actually trying to make a human connection with the person that you're treating. And as David and both Hemant said, it's a team approach. The limb reconstruction nurses are absolutely invaluable, and brutal honesty with the patient, because by the time they've ended up with us, the time for bullshit is over.
Yeah. When you say brutal honesty, I'm always really optimistic with my patients, but that's because I'm always dealing with them in the acute trauma setting, and they just want to hear something happy,
I tell my patients, the most optimistic thing I tell them is I will never, ever lie to them. I will never bullshit them. And obviously at the back of their mind, they're worried about amputation. I'm going to make sure they know what that's all about. And if they don't want to do it, I won't mention it again. But you need to be aware that it's that bad. As long as you never lie to them, you'll do fine.
And Peter, the other thing, so if I'm doing a complex peel-on, a total article, the first thing I'll say is your ankle will never be normal again.
Yeah.
That's the first thing. You start from there, and then, because I think most of the patients will like it if you are honest and you're a realist. because even they know that it's all, it's a bad injury or a bad problem.
Can I ask one last question before we close this up? Nima, last case you showed that awesome cage, like that cage construct, which is 3D printed. Is there any role yet for doing that for diaphyseal segment? So you've got a big old deficiency. Why not just shove in a construct and put a nail up and down, and they can walk pretty much straight away, and then that's rather than spending 2 years in a frame.
I'll see if I can find the slides for you, Pete. Done one. Printed at Stanmore. Don't forget, it's got to come in 2 halves so you can bolt it together when it's cemented bone into bone. But this bloke had a 20 centimetre diaphyseal replacement, custom built by Stanmore Prosthetics Limited. Done very well, very happy.
Absolutely. So there's one.
The only thing I'll say, I live in North. We are very poor. All the farmers live here. We don't have money, so we don't use any such things.
Nima, last word to you.
Yeah, so I think there are a number of companies that are actually looking into this, and they're going to design them. One of the things which is important to recognize is the fact that it's the soft tissue, particularly in the tibia, is the soft tissue that is the problem. I think that in the femur, it'll probably be fine, but in the tibia, we may end up having problems in the future, which are to do with the soft tissues rather than anything else. And as with anything, there are lots of new technologies. We will try them to mitigate some of the really horrible treatments that we have for patients. So watch this space.
Brilliant. All right, guys. I'm gonna shut it down there. It's just after half 9, so we'll call it there. Are there any other things that people want to say? Just to eke it out. Anything else?
No.
We're done. Great. At this point in the webinar, I usually give a little. Put your phone away, Dave. I give a little.
Am I still on video? I'm sharing screen.
I usually give a little summary of my kind of like down-to-earth take, or my kind of like lay take on what I've heard and what I've picked up from the speakers. I usually do this I just putting these down as I go along. First of all, we listened to Hemant, who was talking about assessing deformity, and Nima gave a similar talk about a month or 2 ago, and it's those same diagrams come up, those anatomic diagrams. And I remember as a trainee, I'd think, seriously, you don't actually measure those angles, do you? But actually, what we're being told is that those angles are basically the way you don't mess it up, the way you don't fuck it up, because you can have an easy deformity, which is in one place, and you just correct it and you straighten up the bone. But if the deformity is in 2 places, in the diaphysis, say, and in the metaphysis, and you don't pick up the metaphyseal bit, you will correct the bit that's obvious, like the bit that's straight down the middle of the medulla, and you'll miss the other bit. And suddenly you've swapped one deformity for another one. So actually, and when you've done a limb recon firm, you see this. You see them measuring those angles every single time. It's not just a neurosis; it's how you do it. The patella pointing forward. It's not about the foot pointing forward. It's about the patella pointing forward, and your foot may go wherever it goes, but the patella has to be pointing forward. And the angles keep you from missing metaphyseal deformities. There was a nice beautiful explanation of Cora versus Aka versus osteotomy site. And if they're all in the same spot, then that's easy. I guess the obvious example of that would be a fresh, open, fresh like tibial shaft fracture. The osteotomy, the Cora, the Aka, they're all the same place. And that means you can use any implant you like. Use a nail, use a plate, use a frame, whatever you like. And you put it down, it goes, and it corrects, and it's all lovely. But as soon as they're not in the same place, and your osteotomy is in a slightly different place, then you'll get a bit of translation. You get a bit of an S-bend going on. If your Aka and your osteotomy in a different place, then you'll get a translation effect as well. And so it goes from being very straightforward to quite complex as you start moving these 3 sites apart. Anatomic charts, we talked about that. Deformities can be at 2 levels. So for any deformity, it's not just up. It's obvious. It's right there. Draw 2 lines down the medulla. There's where they cross over. Bang, I'll cut it there and all the rest of it. You do the whole thing properly and you won't screw it up. And right at the end, Hemant gave us a beautiful example of an oblique plane osteotomy. This is the sort of scenario where you've got a bent bone. But AP might be there and lateral might be there. but actually the maximal deformity is somewhere in between those two. And once you've found that spot, then you can say, okay, that is the bit that I need to correct. Dave talked about bone infection, tons of basic science in this and great for the exam. So this was awesome. Don't be an ostrich. Actually, you look quite cool being an ostrich, didn't you? Ostriches look pretty kick-ass, I thought. But anyway, you're not allowed to be one. And I misspelled ostrich first time around. I picked that up at the last minute. Blood supply. As with fractures, blood supply is absolutely key. And obviously pus doesn't have any blood supply in it. So when you see one of those, you know, those on the MRI where you see like particularly in kids, you see that sort of like subperiosteal collection, that is not, you know, the antibiotics are not getting in there. The local inflammatory response, Dave explained really nicely. I'm not going to try and go over those, but there's some beautiful little buzz phrases: Glycocalyx-enclosed colonies, bacterial sessile phase. Basically, the bugs get in there and then they just turn off. And antibiotics, as we know, poison bacteria that are dividing, like trying to make new cell wall, right? That's how most of them work. And so if they're not dividing, they're not taking on board antibiotics, they're just like hanging out. I love that thing of quorum sensing. So they stay in this sessile phase until they kind of get this feeling that there's enough of them to really kick off. And that's when they start dividing again and causing an acute thing. And really, once they're deeply embedded in the bone, I love that thing also where you get these avascular areas that get colonized, the biofilm forms, but the body manages that by making an involucrum over the top, around the side of it, like kind of wraps it up, right? I'm going to bury you in new bone. And so you get that, we have that lovely diagram you can see on the right of an old bit of femoral, diseased femoral shaft, totally wrapped up in new involucrum, but not normal involucrum. And that's why he chopped it out. Not normal, that's full of disease as well, albeit vascularized. Classification, we talked about diagnosis. Pus swabs are not helpful. So taking swabs out of the wound, that's going to give you a polymicrobial response. MRIs show residual metal. So although you might see an increased signal, it may not be infection. And PET over bone scans is probably how imaging is moving on now. And finally, we talked about the treatment from 1s to 4s, and the common threads and the threads that came throughout this webinar were microbiology. Microbiology is not just about taking a sample and sending it off. There's a huge science around it, and having a good relationship between you and your microbiologist and having an MDT there is equivalent to having a good orthoplastic MDT and a good relationship there. It's a key element, one of the foundations of limb reconstruction, and indeed arthroplasty these days, of course. Hold off antibiotics until you've got samples. That's common thing throughout ortho. Local antibiotic delivery, stimulans, one of the commonly used things. It does produce a lot of fluid. That's something we didn't mention, but how you manage that massive kind of fluid response after stimulan is definitely a discussion point. And infected bone needs chopping out. And in order to do that effective debridement, it's not just chopping out the bone, it's about taking the diseased soft tissue away as well. And to do that, you've got to have total confidence to do it. And the only way you get that is by having a kick-ass plastic surgeon as well. So orthopod, microbiologist, plastic surgeon, frame nurse, and all of the other people that go around that. But there are some absolute cornerstones to the limb reconstruction setup. Finally, Nima talked about bone loss, and I love the way we talked about partial versus segmental. And there are different ways you can do partial, and it's wrong to have a talk about this without talking about this idea of putting bone back in, so-called retained fragments. You've got a big old butterfly, it's totally devitalized. You take it out, you clean it up, you put it back in again. It makes a lot of intuitive sense because it is structural. The take-home message from that group, from the Bristol group who published that, is very, very clear. In order to do that safely, you have to be able to stick some meat over the top of it afterwards. You either got to be able to primarily close it or get a flap on it straight away afterwards. Doing this is like, I'll retain it, put a plate on it, and the plastic surgeons will come back in 5 days' time to cover it. That will not work. We talked about spare part surgery. Using fibulas was a nice example. Using a bit of lateral malleolus to go in here, where you need a bit more structure for partial defects. Segmental defects, Nima talked about critical size defects, and that varies depending on your patient, depending on the soft tissues and all sorts of other things. But 2.5 is a number that seems to be beyond which even magic can't help. Although I guess in adolescents and kids you can go much longer than 2.5. New stuff is plate assisted, nail as a rail, plates as a rail. You saw that lovely femur being with plates on both sides, so that you can lengthen the bone inside them and the patient could be weight bearing in the meantime. Telescopic nails, similar, same technique, but similarly, you can't walk on a telescopic nail there, so the plates almost protect the telescopic nail. 3D constructs is where we ended up, and there's a huge amount of work going into that, because that could be a bit of a golden goose going forwards. Acute shortening is a powerful tool, because you can acute shorten, get your union, and then lengthen afterwards, which is a great way of getting union in a difficult situation. Finally, Nima talked about foot injuries. Never forget, if you've got a bad foot or an absent heel pad that's got to need some kind of flap coverage, often they do better with a below knee. And we talk finally about the patient journey, about this whole psychology, the importance of a frame nurse. If you've got a psychologist, boy, they're helpful. But I tell you what, it's the frame nurses that basically do the psychology stuff. I hope I haven't missed anything out. I hope I haven't undersold any of your talks. And thank you once again for my faculty. They were totally awesome today. And Nima, thank you so much for co-hosting this. It's great to give this some credibility alongside me. Thanks very much.